Republic Day. What a day to start this particular webinar as a learning platform for all the students. So we have Dr. Shayansh Kothari, who will take us through the topic of genetic testing in fetal medicine. And we have our R&D head, Dr. Nilanju from Metropolis Healthcare Limited, who will be moderating the session. Wish you all a very happy learning. Thanks. Dr. Nilanju.
A very good Republic Day to all of you. And today, it's a very, as Sarini has mentioned, very good way to celebrate Republic Day with a very exciting topic with genetic testing, fetal medicine. And we have amongst us one of the, finest fetal medicine expert of Mumbai, Dr. Shreyans Kothari. Dr. Shreyans is a highly skilled and dedicated radiologist with a diverse range of experience across several esteemed hospitals and diagnostic centers. Currently, he is the managing director and fetal medicine specialist at Imaging Point. He has a MD in radiology from United States of America, and he has a fellowship in fetal medicine. He has honed a deep understanding of imaging technologies and diagnostic techniques. So let us hear today's, very enticing talk from Dr. Kothari. Welcome to the webinar, sir. The stage is yours now. Thank you. I welcome you for the session.
Thank you, Dr. Nilanju, for your kind words. I would like to thank everyone to be present here on a Sunday early morning. And a very good morning and happy Republic Day to all of you all. Let's get into the basic introduction, just a rush through the basics of genetic testing in fetal medicine. So as we all know, there are cells in a body that have a nucleus, and there are 23 chromosomes. The 23 chromosomes, just imagine it as a chapter in a book, which when opened down, you get DNA. And once the DNA, they're like sentences. Once the DNA is again broken down, you get this double-stranded helix. And the double-stranded helix could be like words. Once these words are again broken down, we are made up of multiple combinations of nucleotide base pairs. And these combinations, they express different kind of proteins in our body. So let's get back to the fetal medicine half of it. What is known by us, right? So fetal abnormalities are identified in 2 to 5% of pregnancies. Fetal anomalies are responsible for 21% of perinatal deaths. And the outcomes and prognosis depends on the nature of the abnormality. Are they isolated or multiple, or any possibility of a genetic etiology behind it? Now, what are the indications for genetic testing? All right. A positive aneuploidy screen, family history of a genetic disorder, couple are carriers of a genetic disorder, fetal malformation, or an intrauterine fetal demise. These could be an indication for getting a genetic test. What are the disorders that we are looking for, that we are trying to test out here? One is a chromosomal and a single gene disorder. Now, digging a little deeper, the chromosomal abnormalities are divided into abnormalities in number, which are aneuploidies, diploidies, and tetraploidies. And then you have abnormalities in structure, which are balanced, where all the genomic material is preserved, it's not lost, all right, but it's just rearranged. Whereas in an unbalanced kind of an abnormality, you have deletions, duplications, and missing genomic material. So just a brush through, just a recap. This is not a genetic class, but just for our information, I just put this classification. So as you have chromosomal abnormalities, you have aneuploidies, and which are extra or missing chromosomes. Then you have monosomies. Then you have trisomies, and then you have polyploidies, where you have a whole set, of chromosomes, which could be tetraploidies or triploidies. Then you have a structural abnormality, which could be unbalanced. With the types are deletion, duplication, insertions, or rings. And then you have the balanced kind, which is inversion and translocations. So coming back to fetal medicine, it is very important for us to know the evolution of aneuploidy screening. It all begins with screening, all right? And after screening came the genetic test. So let's see the evolution. In 1990s, any the maternal age of more than 35 was considered. It was due to the aging, the biological aging of the mother's ovary uh, that these mothers were considered for this particular screening. Then in the 1990s, the second trimester biochemical screening was considered. In 2000s, the first trimester combined test was taken into as an important screening test. And then in 2015, we had the revolutionary cell-free fetal DNA test, the NIPD test, which was introduced, which was really revolutionary. Um, so let's dig a little deeper into first the screening and then coming into the genetic half of this, which was revolutionary, and it brought a big change in field medicine. So the second trimester biochemical screening, which was introduced in 1990, this test was basically refers to a blood test, which is typically done between the 15th and 28th week. There are 4 markers that are tested for, which are the alpha fetoprotein, human chorionic gonadotropin, unconjugated estriol, and inhibin A. There was a predecessor, an older version of the quadruple marker, which did not have the inhibin A, which is the triple screen. The interpretations would be basically an abnormal levels of these markers when combined with the maternal age can indicate an increased risk for a certain genetic condition. And if they fall into a high risk, further testing like amniocentesis may be recommended to confirm the genetic diagnosis or get to a diagnosis. Now coming on to the first trimester combined test, which is introduced in 2000. So this is also a very important test, which where 2 biochemical markers are analyzed and combined with the maternal age and nuclear translucency measurement to generate a combined test result or a risk ratio, which is used today. The biochemical markers are pregnancy-associated plasma protein A, which is PAP-A, and the free beta HCG. An accurate measurement of the fetal crown lump length and the nuchal translucency is required, all right, to get the most accurate risk ratio. So this risk ratio is used in the contingent screening, which I'll be talking about a little ahead. So now coming on to the main thing where the genetic testing all begins. This started in 2015, which is the cell-free fetal DNA. The NIPD test is basically a non-invasive blood test, and it tests for chromosomal abnormalities in a fetus. It can be the test can be done anytime after the 10th week of gestation, and a simple blood sample is taken from the mother. The sample is analyzed for the presence of cell-free fetal DNA, which is the DNA from the fetus that circulates in the mother's blood. Now, what can it detect? So a cell-free DNA testing detects conditions caused by abnormal numbers in the chromosomes, such as Downs, Edwards, and Pataus. It can also be used to detect monogenic and chromosomal pathologies. And like I said, it can be detected after the 10th week up to delivery. And it can also be used to detect some cancers and to monitor cancer therapy. Very important point. So what is cell-free DNA? we have the small animation that is made it very simplified. Obviously, I've taken it from the American Society. But let's go through this video.
IPT, or non-invasive prenatal testing, is a screening test that can give you valuable information about your baby's health before they're even born. During pregnancy, the baby releases cell-free DNA into the mother's bloodstream by taking a simple blood sample from the mother's arm. As early as 10 weeks, doctors can analyze this DNA in a lab to detect abnormalities in your baby's chromosomes. It is considered the most accurate and modern method to screen for conditions like Down syndrome, Edwards syndrome, Patau syndrome, and other genetic conditions depending on the test provider. NIPT's main strength is in its high negative predictive value, meaning that if the test is negative, the chances of your baby having Down syndrome are extremely low. In contrast, its 90s predecessor, combined screening, offers both a lower 80 to 90% detection rate and a 5% false positive rate. However, it's important to note that NIPT is not a diagnostic test and does not provide a definitive yes or no answer.
So yes, like I said, it has been revolutionary, but we always prefer to get an invasive testing done. Okay, coming on to this is one of the most interesting research papers that has been published. It's called the Trident 2 test, which was done the first year, which was done in from the 1st of April 2017 to 2018. This test was conducted with 73,239 pregnancies were tested for cell-free DNA as a primary screening modality, and more than 97% perinatal outcome was achieved, which is a very good study. Out of the 73,239 pregnancies that were tested, 343 were positive for either for Downs, Patau's, or Edwards syndrome. All right. So here is the distribution. All right. For Downs, out of the 343, 239 were Down syndrome patients. And as you can see, the positive predictive value and the sensitivity is very high. Along with for the Edwards and Patau syndrome, the sensitivity and predictive value is very high. But then again, we do require invasive testing for proving the same. Cell-free DNA is used for typical trisomies, sex chromosomal aneuploidies, atypical trisomies, deletions, duplications, microdeletions and microduplications, and also can be used in specific types of gestation, that is in twin pregnancies and in assisted conception. Strategies of clinical cell-free DNA application. Like I said, if on ultrasound, if you find any marker, then we can obviously advise the patient for getting an NIPT done, or use it as a primary, secondary, or a contingent screening test. Extended cell-free DNA testing, like I said, it can be used for typical trisomies, sex aneuploidies, atypical trisomies, deletions and duplications more than 10 MB, and microdeletions and microduplications less than 10 MB. So the analysis of cell-free DNA in maternal blood has shown to be highly specific and sensitive method for screening for typical trisomies, whereas the positive predictive value is very high for typical trisomies, approximately 74 to 96%, low for atypical trisomies, 5%, and intermediate for the remaining anomalies, which is 40 to 44%. Obviously, there are a lot more genetic tests that are available in today's day. So I would just like to give you a differentiation of the common ones that are used, the genetic diseases that can be detected by karyotyping. So the large anomalies can be easily detected and seen under the microscope. Half of them will be 21 Downs. About a fourth would be Edwards and Patau, and some would be monosomy X. So always remember that in karyotype, you cannot detect any micro deletions and duplications. Then you have the microarray. The same, you can see large anomalies, but whereas in this you can pick up microdeletions and microduplications, whereas monogenic diseases are not detected in here. So one last thing about cell-free DNA, the performance in IVF pregnancy. Is cell-free DNA testing less accurate in IVF? Yet a big question. The median fetal fraction is lower in IVF pregnancies as compared to spontaneous conception. What does this mean? This means that the amount of the fetal DNA that can be segregated from the mother's blood, the availability of the fetal fraction, is it less in an IVF pregnancy, is yet a big question. The other thing is that is cell-free DNA testing the elective test to confirm PGTA? So a PGTA does not confirm the birth of a chromosomal normal child. All right. So first trimester screening and testing for aneuploidies is always recommended, no matter if a PGTA test is done or no. Take-home message. Now, secondary screening. What are the secondary invasive screenings that are available? You have amniocentesis and chorionic villus sampling with a fetal loss of 0.1 to 0.3, and you have cholecentesis and biopsy of the fetal tissue. So let's just get a glimpse of
Remember, screening
procedures.
tests show only the chances your pregnancy has a genetic disorder. A diagnostic test can show if your pregnancy actually has the disorder. In diagnostic tests, cells are taken from the placenta or the amniotic fluid surrounding the fetus. These cells contain the same genetic material as the fetus. The cells are collected with a tube or needle and are sent to a lab for testing. There are two types of these tests: chorionic villus sampling, CVS, and amniocentesis. CVS can be done earlier in pregnancy than amniocentesis. Both tests come with a small risk of miscarriage. There is a slightly higher risk of miscarriage with CVS than amniocentesis.
So amniocentesis has a 0.1 and CVS is a 0.2% chance. Now, what is the contingent screening, the Caroline experience? So after getting the first trimester screening, combined the risk ratio, we have come up with this table, which simplifies everything. So if the risk ratio is equal to or in between 1:9, which is super high risk, you have to advise them an invasive testing. Whereas if it is 1:10 to 1:250, which is again a very high risk, we offer invasive testing and NIPT. If the risk ratio is between 251 and 1100, which is an intermediate risk, we should only offer NIPT. And if it is more than 1100, which is no risk at all, we don't do anything, but we get a detailed ultrasonography done. This is just a this is a table that gives us overview and a small introduction, the basic of all the tests available after amniocentesis, the turnaround time, the nature, and the conditions that it's used for. This FISH, QFPCR, karyotyping, chromosomal microarray, molecular DNA base pairs, and the next generation test, which is the whole exome sequencing. All these tests have been revolutionary and they've brought a big change in the diagnosis, in the management of the next pregnancies in case of any previous history of any aneuploidies of any chromosomal. So the take-home message for today would be that the first trimester combined screening is done for all pregnancies. If you get a high risk, we offer NIPT, which is a non-invasive test and is highly sensitive. Amniocentesis can be offered to those who have a high risk in the combined first trimester screening test, or to those with a positive NIPT, thereby eliminating unwanted invasive procedures in pregnancies. And invasive procedures is the final answer for genetics in fetal medicine at present. Thank you, guys.
Thank you so much. Thank you, Dr. Kothe. It was a really very, crisp presentation on genetics, I would say. Now to, just more have more understanding of of your clinical practice. So how often do you prescribe genetic testing in your day-to-day cases? How much, how much percentage maybe, and how it is useful for your practice? Can you just elaborate on that part a little bit?
Well, to tell you the truth, NIPT is, like I said, it is used by a lot of people as a primary screening, secondary screening as a contingent screening. Primary screening, in fact, because of the awareness and even the growing the awareness in the growing population, and people come up to me who are above the age of 35, and they get advised by a lot of gynecologists. And a lot of people in today's day and age about the age of 35 want to get tested because it's a non-invasive test. NIPT is highly recommended, and I've seen it, like, in today's day and age, a lot of people are getting it done. It is, like I said, it's a non-invasive screening test, and hence there are a lot more people who are ready to get it done as compared to getting an invasive testing, because that gives you almost a short cut answer regarding your fetus and if there is any chromosomal abnormality, along with that, it has a very high sensitivity and of approximately 97 to 98%, which is which should be a very good screening modality. So I guess there are a lot of women who get it done in today's day and age. Approximately, I get to see around 10, a minimum of 5 to 10 women who get it done every week.
Yeah. Thank you. And then, for per se, a couple with a recurrent pregnancy loss comes to you. Then, as you have mentioned that, NIPT can detect, it's a screening test. At the end of the day, it is not diagnostic, very, very sensitive screening test, which, as per ACMG also, they recommend NIPT should be done for all women, irrespective of the risk group, right?
Right. I
Now,
completely agree.
yeah, a couple comes with a recurrent pregnancy loss, and then you have done NIPT, but then again, that was fine, but they have lost the pregnancy. Now, would you recommend microarray in that case to see the fetus first, the POC testing that we do from microarray? And would you recommend the microarray testing in a RPL case?
In a what case? Sorry, RPM.
RPL, yes, recurrent pregnancy loss cases. Would you recommend the microarray?
Absolutely. So all these genetic tests are recommended for recurrent pregnancy losses, because then we get to get down to the cause of it, and then maybe we can. It is recommended because we can understand and even make the management, knowing the history or the genetic history. The most common cause for RPL is genetic abnormalities. And it's all about management, going down to the root cause of the recurrent pregnancy loss. And hence getting the pedigree, the genetic pedigree is very important, so that we know the risk and we can guide the parents for the next pregnancy.
Yeah, thank you. So, from a clinical point of view, as a clinician, you are definitely, you support the genetic testing that has come on the advancement of technologies, right? From starting from karyotyping, FISH, microarray, and now we are having next generation sequencing, where along with the microarray will detect us the copy number variation, as you have said, deletion, duplication that can be detected by microarray, right? While we are doing a exome sequencing, it will also see the point mutations if they are the carrier of any autosomal recessive conditions, right? So that will also give us an insight into their genetic makeup if that is the cause, right? So from a clinician point of view, you are saying that genetic testing is definitely helping to, sort out your critical cases.
Absolutely.
Thank you so much. It was a very, excellent presentation, and thank you for addressing all the queries. And if there are any more queries that comes up,
just email it to me or anything. I'll provide my email address and my phone number. Okay.
Thank you so much.
All right.
Thank you so much. Thank you,
Thank
all,
you, guys,
everyone.
and thank you all for being present.
Thank you.
All right. Good day, guys. Bye-bye.